you very much, Pradeep, for the kind invitation to be here. I'm always happy to come to the UK, and especially to such a nice organized conference. And I looked out to the rest of the program today because I'm happy to attend as well as to present. So my topic indeed for today is the serrated polyps. This is what we all do all day. We hope to prevent colorectal cancer by in time resecting polyps. And it has always been the paradigm that these polyps were adenomas. That's what we knew up until recently. If you take out all the adenomas, and we're talking about detecting them well, you would be able to prevent cancer. However, recently more data have become available, and we are not so sure whether adenomas are the only ones anymore we should detect. So there's a lot of debate about the other kind of polyps, like the sessile serrated adenomas and the hyperplastic polyps. What is the group of serrated polyps? And I think this, if any message, I think this is one of the key messages for today. There's a lot of debate about the different categories of polyps. And there's a lot of mixing up these polyps. But this is what is the definition. Serrated polyps is the whole group of polyps together, being hyperplastic polyps, as well as sessile serrated adenoma / polyp, and traditional serrated adenomas. And that's, of course, this is difficult to remember, and things get mixed up easily, especially for the sessile serrated adenoma / polyp, which is a strange name, and also because sessile already says something about the Paris classification, and it's not. In this term, it's just meaning that type of histology that I showed you in the previous slide. So please remember well these definitions. And within the group of sessile serrated adenoma / polyp, it is even more difficult because there's polyps with dysplasia and without dysplasia. So the group is called serrated polyps, but the special type is called sessile serrated adenoma / polyp. I can't do anything about it. I would like to highlight that we have learned a lot about the traditional adenoma carcinoma pathway from patients with FAP, and Andy Latchford will talk later on all these different polyposis syndromes. But I would like to stress that in a patient with multiple adenomas, this really helps us in understanding the adenoma carcinoma pathway, the traditional one, like has been shown here. These patients are like walking laboratories, I would almost say. I have a colleague doing IBD research, and he always says, I don't need a biobank, I have my patients walking around, and anytime they come I have